come may change the inferences that are drawn. I hope I am audible.
Yeah.
Yes, sir. Yes, sir.
Yes, sir. You're audible.
Now, if you look at where are we today in India, you find that all the spikes have gone. The number of new cases have dropped down. It runs into only 4 figures and even somewhere around 1,000 most often. And when it comes to deaths, deaths have also got reduced to a larger extent. We saw the dance of death sometime during Delta wave, which is very much evident in the slide that you are seeing. But at the same time, when this was happening, one of the things that was also happening is the mask use started dropping in India. You find that even from the peak, almost a third of the people they're only using mask as of now compared to what it was before. And people started relaxing a lot at this juncture. And then suddenly, what you find is the top 10 countries, which used to be traditionally India and European bloc and US, that suddenly changed. And you have now top 10 countries, which are represented by Japan, South Korea, China, Taiwan, and New Zealand. They had followed a zero COVID strategy. These are 5 countries out of 10 where the spike is suddenly seen at this point in time. You look at Japan, you suddenly find a small country. It has a population of close to about 12 crore, 12 and a half crore population. You suddenly see the spikes. They are running into 200,000 to 250,000 a day. They have started declining only recently. But if you look at South Korea also had a similar kind of a issue. It has only about 5 crore population. But the biggest spike that was seen was almost closer to what we had seen even during Omicron wave, which was 4 lakh people getting infected at one point in time. Now, why is the spike occurring in those places? They had zero COVID strategy. Japan, New Zealand, and China have now opened up. And when it comes to China, which everybody tends to worry, and the reasons which we will see subsequently, in China, they abruptly lifted the zero COVID strategy. So everybody in the surrounding, everybody on the street suddenly becomes vulnerable. They have used whole inactivated vaccine, and we know that we don't trust the data that tends to emerge from China as easily because of lack of transparency. But there were many countries to which China had actually donated their own vaccines, which they have used in their own country. And these countries reported lower efficacy, which ranged between 51 to 73% versus what was reported from China as about 95%. And these are the countries which drop use of these vaccines, which are whole inactivated vaccine. Now, 17% of the elderly population is there in China, and therefore deaths have to be more common compared to 6% in India. One must remember that the Omicron variant has a R0 value at present in China, which ranges between 10 to 18. But can this be a true estimate per se? You cannot say so, because at this point in time, home-based testing is also common, and this is a Omicron variant where you find people who are asymptomatic. They don't turn up to even do their own testing, and the result is this becomes an underestimate. Even if this is a milder variant, a large denominator and a large population size of elderly population, you will suddenly find that the numbers that are dying or getting hospitalized has to be very, very high. When it comes to new infections, we should not be surprised if we say that at any given point in time, that you might on a day you might find that the numbers having new infection could be anywhere between 40 to 60 lakh people, mainly because everybody is vulnerable and everybody is getting exposed because of the newly found freedom. Because of the protests that have been made, everybody is moving in that particular direction. And what is also important to remember is there is colder temperature, which makes people stay in the home, and therefore they get to get exposed because of lack of ventilation in those areas. And the black box with China, because of which we tend to get worried, is a huge population size of 1.41 billion population. And now they have officially stopped reporting cases itself. So nobody has any clue as to what is the number that is getting infected as of now, the number that have been hospitalized, and the number that is dying. And naturally, we also do not know which is the variant which is actually infecting predominantly the population in China. This outbreak in China evoked the fear of unknown, mainly because there is low transparency. Second fear that we have, will they ever report newer variants in timely manner? Will it lead to new wave akin to Delta that we have seen in India and rest of the world as well? And naturally, the government responded in a different manner to reduce the panic that may be existent. We do not know whether it is a cause or an effect. They strengthened the genomic surveillance, test all the passengers from China and certain other countries in the bloc, and 2% of international travelers, and anyone who comes out as positive, they have requested the samples to be sent for genomic sequencing to identify any newer variant that tends to come out of it. Mock drill for oxygen, the beds, the ventilators, and trained manpower have also been conducted. Use of masks has been promulgated in certain states. Some of us tend to feel that it is an overreaction. We'll try to understand whether this is an overreaction or this is something which we had to do in order to reduce the fear based on some scientific probability, which may be smaller if some people may consider it as smaller. The more the infections, one of the principles is the higher is the likelihood that a new variant may emerge. And all of us know that you have close to about 1.4 billion population, which is likely to be vulnerable in China. So there is a fear that a new variant may emerge. If you look at the global genetic epidemiology of SARS-CoV-2 pandemic, you find that the Omicron variant was reported sometime in the month of November, November 23rd or 24th in 2021 in South Africa. Prior to that, we had Wuhan virus, we had Alpha, then we had Delta, we also had Beta in between. And now what you are seeing for last 13 months is Omicron variant in different forms, in different variations that tend to exist within, which we'll try and understand. If you actually try and look at what has happened in India, where we by and large tend to say that majority of the population has already been exposed to Omicron variant, you find that BF.7 has hardly been reported from INSACOG. If you look at that particular diagram, I can understand that it's very difficult to infer from the diagram, which becomes complex when it is being compared with rest of the world as such. Most of us think that we are moving towards endemicity, and Chinese outbreak is unlikely to affect us. The reasons that we quote are we have two dosages. We have a high coverage with a vaccine. Two dosages are being given to the adults, and these vaccines are of better quality. We have hybrid immunity because we got infected by Omicron or Delta or some other variant earlier. BF.7 and variants are from BA.5 lineage. So essentially, BA.5 was also present in India. So there is not much of a reason for us to worry whether BF.7 can spread rapidly or any other recombinant that is occurring can spread rapidly. Because one basic principle that we have to keep at the back of mind is recombination is an accidental event. It does not offer any survival advantage to the virus, and therefore these lineages are unlikely to survive longer and predominate. Say the variants that are reported from China have not been reported to have a higher virulence per se, and we are better prepared due to our past experience. But now let us look at the science part of it. The rate of change or mutations or substitutions that tend to occur globally has been 26.5 per year across the world. So the rate is 26.5, but when you look at what is happening in Asia in last 6 months, it is 31.15 per year, which means there is perhaps an increase that is being observed here. We do not know whether it is a reflection of large population size and continuing pandemic in this part of the world. We still don't have sufficient idea about the same, but it is true that the mutation rates are higher in this part as of now. Now, if you try to compare the variants between the West and the East, what is it that we are seeing? We are seeing that BQ1 is more prevalent in the West, but when it comes to the eastern part of the world, you find BA 2.7.5 and XBB variant is more common in the eastern part of the world. Now, if you look at BQ1 has never been reported in India so far. BA point 5 has actually was outgrown by BA 2.75 in the earlier part of the outbreak that occurred in Omicron. But do we understand the significance as to what does this signify when it comes to BQ1 or BA point 2.75? The differences that we are seeing in East and West, we don't, because there is one part which we have to understand. It also depends on the local transmission dynamics that tend to occur, the mobility that tends to exist within the population, and who is moving, who is getting exposed. They also decide the local dynamics. So it's very difficult to infer based on the differences that we are seeing. As of now, we treat everything as equal for all practical purposes, as even if there are differences. The dangerous sites for mutations that we have seen is in Omicron. You have close to about 21 such critical sites, and these sites are shared by all the sublineages of the Omicron per se. And what do these sites do? There would be mutations that will occur. They will impact the binding with the receptor and therefore affect the transmission efficiency. Now, if you look at 10 mutations that tend to occur, they are in the receptor binding domain, and therefore immune evasion is a common phenomena. Immune escape is a common phenomena among all these mutants that are coming. Now, if you try to look at the number of mutations that tend to occur of the 21 that we talked about, and try to look at the growth advantage that it provides to the virus, you realize that the more the number of mutations that tend to occur, you will find that the growth advantage tends to be higher as the number of mutations increase in that particular viral variant. What is a convergent evolution? This is a term which we have to try and understand. That convergent evolution is one wherein there distinct lineages independently evolve into similar traits phenotypically, which means they are evolving from different variants per se, but eventually all of them are trying to do the same thing, increase the transmission efficiency or virulence. And in this case, it is transmission efficiency. And if you actually look at a cross-sectional view, you will find that you would have multiple variants having similar kind of a transmission efficiency. They may have small genetic changes within, and this particular phenomena, which is also called as a soup, it's compared with the soup, is called as convergent evolution. If you look at current variants and try to look at them, you will start realizing, look at the number of variants that one can actually see. And these variants could be present in any country at a given point in time. None of them tends to predominate because they are almost having equal age in terms of transmission efficiency or whichever evolutionary feature that they have adopted. Now, does this viral evolution always lead to increase in transmission efficiency and reduction in virulence? Perhaps not. There are aberrations. By and large, this rule works well, but there are aberrations that tend to occur. If you were to even look at SARS-CoV-2, you find we had alpha and then suddenly delta, which also had a higher virulence than the Wuhan virus, the original Wuhan virus that was there. If you look at even influenza, the second wave of influenza had higher virulence than first. But one thing which we must remember, what we understand commonly is likely to happen occur as commonly as one can imagine and therefore increasing transmission efficiency may be more common, and reduction in virulence is also something which is likely to persist over a period of time. Now, one consolation that all of us have, after its first report in November 2021, the lineage reported variant, the lineages of the reported variants continue to fall under Omicron for last 13 months. And why do I think it is important? Because if you look at the past, every wave with there were different variants that were predominating, and these waves used to last between 4 to 5 months time. There would be a new variant that would emerge, and that variant would take over, and a new wave would start. But here in Omicron, now we have spent close to 13 months, and still we are yet to report anything beyond Omicron at this juncture. But there are certain features that we must keep at the back of mind and worry a little bit about from scientific angles. These viruses tend to mutate due to, first thing is error-prone enzymes which are used during replication, and therefore mutations tend to occur. You have immune pressure which may be induced by vaccine, or natural infection may also induce immune pressure, and the drug pressure that could come from the medicines that we tend to use. Now, these are going to challenge the virus to mutate in order to see that it survives, and the balance between in the battle is also maintained between human beings and the viruses per se. Now, we look at the vaccines. Do we think that the vaccines made a difference? Of course, they made a difference. If you were to look at the model data on no vaccination versus vaccination, you find there has been a drastic reduction in terms of not only mortality, but also in terms of number of infections that occurred, and even among the prevalence figures that were estimated at different time points per se. But there is something which we have to remember, that this virus continues to mutate, and when it mutates, the first thing that happens is these mutations tend to be commonly seen among spike proteins, and spike proteins are used for entering into the cells of the body, and therefore you will find that if there are escape mutants which will emerge, these escape mutants will ensure that the protective efficacy of vaccines against getting new infection will always be lower compared to that of hospitalization and severe disease, as we talk about. And the reason is very simple. If you want to protect yourself against this particular new infection that is likely to come, you must have higher titers of neutralizing antibodies which are present there, which is unlikely to happen because the immune system tends to see that the protective levels of these antibodies tend to wane off over a period of time. And naturally, the protection against infection is likely to be lower, and the virus is going to mutate only against it. Do we have some kind of evidence of the same? If you actually look at different mutants that are coming, different variants that are coming, you find that the decline in efficacy is more against infection compared to severe disease. But if you actually look at the vaccines that have been used in China, you find that the decline, whether it is Sinopharm, whether it is Sinovac or CanSino, you find that the decline is massive, mainly because they have used a traditional adjuvant as against the one L-hydroxyquine 2, which we have used against in the Covaxin that we have developed internally as whole inactivated vaccine. When it comes to, but at the same time, there are certain disturbing papers that you will read. In certain papers, you will find that the proportion of deaths among vaccinated persons is increasing. If you look at overall increase, you will suddenly find that from December 21, where there were 5% people who were dying despite receiving vaccines, the proportion has gone right up to 38% as of now. If you compare that with those who are elderly, you find it becomes far more exaggerated. But why is this happening? This is happening mainly because of the waning immunity and people, most of the people have received vaccines, and those who are vulnerable, those whose immunity has waned off, they tend to get infection and succumb to this particular infection per se. If you actually look at immunity that has been offered by Covishield, one of the reasons why we need to be worried about and we need to be vigilant is if you compare Covishield with mRNA vaccines and J&J vaccine, whether the waning immunity against infection after second dose or against severe disease, and try and see who is the one who's likely to have lower efficacy, you will suddenly find Covishield stands out pretty prominently as the time passes by compared to mRNA and J&J vaccine. So there is a reason for us to worry about to some extent at this juncture. We'll try and see what we can do subsequently. But what about natural immunity? Earlier we saw this was because of vaccine-induced immunity. But when it comes to natural immunity, you will find that the immunity against hospitalization and death tends to be retained for a longer period of time and in a better proportion compared to that against infection. And why is this happening? Mainly because all this particular infection is going to stimulate T cells. And when it is stimulated, you will find that these T cells are trained to generate these antibodies against the infection, but it takes some time to generate the same, and therefore they are not able to protect against infection, but they are able to protect very well against hospitalization and death as a complication per se. The neutralizing antibody titers tend to be higher among those who had prior infection. Now, if you look at this particular graph, you will realize that there are people whom no prior infection had occurred and we provided the vaccine. This is all mRNA data, unfortunately. And there are people who had prior infection, and that is being compared at this juncture. You will certainly find those who had prior infection at the background, you find that their responses for neutralizing antibody titers has been exceedingly good. Hybrid immunity, therefore, is better than all. Now, do we have real time or real life kind of data? This comes from Qatar, where vaccine effectiveness has been compared with those who had prior infection. These are people who had hybrid immunity, which is in red color per se. Even if they received two dosages, people who had hybrid immunity, they tended to show better effectiveness using these particular vaccines. If they had three, this proportion suddenly increases of effectiveness at a higher level per se. So essentially, what does this tell? If you have hybrid immunity, if you had previous infection, you tend to perform better. Now, when you think in terms of effectiveness, data that has been generated by Pfizer, you will suddenly find that vaccines have been effective against severe Omicron illness, but they tend to wane off. This particular protection tends to wane off 9 months after second dose per se. And this duration of protection is close to about 6 months, post the boost that has occurred. And therefore, what does it tell us? That it tells us that we should not treat Omicron infection as a natural booster. We need to take a booster after infection, which will protect you better. And therefore, we must advocate for taking boosters to everybody who thinks that having got Omicron, I don't need a vaccine. This opportunity should never be lost because you are going to retrain your T cells more than twice. And therefore, it helps you in generating a stronger response whenever the T cells will encounter these viruses in our body and protect us against hospitalization and death. Now, most of these infections, Omicron-related infections, are going to be mild and manageable in outpatient departments. What is the good news in that? If you look at Paxlovid, it works against Omicron. Uh, Earlier, people were little worried that the efficacy may be of 89% if you use Paxlovid it may come down among those who are vaccinated or partially protected to about 50%. But this data is little difficult to understand, mainly because you are comparing clinical trial data with the observational studies data, which becomes little less reliable per se. But it is possible that there may be a drop in efficacy if you use Paxlovid among those who are vaccinated. There may be a rebound that can occur in 10 days after receiving the dosages of Paxlovid, and these could happen between 5 to 15% of the individuals. We may not require to treat them, but isolate them per se. Is Paxlovid going to be available for us? Yes, Paxlovid is being made available, and Hetero has also qualified for WHO pre-qualification. Therefore, perhaps Paxlovid's absence in our Indian scene may not be something which we will see continuously in future as well. You could use remdesivir, monoclonal antibodies, convalescent plasma, and molnupiravir. The question mark continues to be there because of reasons that we all know. A news item in China from China tended to say that Paxlovid is being made available in China. Now, this is little worrisome from theoretical angles. It can exert a drug pressure on the virus to mutate. Mutations have been reported on exposure to Paxlovid. These can cause mutations at 166 and 50 sites at the end of 5 days of treatment itself. Now, that's something which is worrisome. And there are certain cleavage sites where these mutations can also occur. Though we still do not know the significance of these mutations, there is a reason that we should keep this at the back of mind, that mutations may occur and we do not know whether they confer drug resistance, and watch for what happens in China at this point in time. When you think in terms of monoclonal antibodies, so far, 5 monoclonal antibodies had been approved by US FDA. Unfortunately, these monoclonal antibodies have a shorter market life. The reason is very simple. The viruses tend to mutate, and they tend to overcome the responses that these monoclonal antibodies would like to have from these viruses, and they remain vulnerable all through. Even the last one, the Tixagevimab and Silgavimab, even it doesn't work against the viruses variants that are currently being reported, as shown in the cartoon that you see there. And that's something which is a worrisome feature. Now, what is also important is these were 5 which are approved, but when it comes to comparisons with those which are still in the developmental phase, you find that most of these new variants that have emerged tend to ensure that these monoclonal antibodies do not work. And therefore, the big question that is likely to come up is, will companies continue to invest in development of newer monoclonal antibodies? Perhaps not, because they may find that this is going to be a cost intensive activity and they are unlikely to make any kind of profits in the same. The reason why this I am quoting is presence of use of monoclonals could also have had impacted generation of newer variants and newer mutations. But fortunately, this is unlikely to happen because this may not be used so commonly. Now, one of the things which we have to remember, which I had discussed earlier when we had a presentation in the last time, we know that Omicron has so much of variation from the Wuhan and Delta virus. And we also know that uh, this particular virus, SARS-CoV-2, also is found among different animals which are susceptible to get this infection. So a newer concept came that Omicron actually originated from reverse zoonosis as a phenomena. Like we talk of human beings getting this particular infection from bats, now from human beings, the infection goes to different animals, most often those which are domesticated animals or those who are in zoo. And from those, would we get it? We still have a question mark in our own mind because we don't have a direct evidence as of now but it tends to provoke one for thinking that the next variant of concern may be far different than Omicron or its predecessors, because Omicron by itself was far different from the earlier viruses that had come. Now, what could be the immediate future of the pandemic? What we would like to see, that we would benefit the most by perhaps elimination or eradication. But is that possible? It's not possible. Elimination and eradication is a very tough goal unless we have a powerful pan-corona vaccine that emerges on the research front per se. But what you are likely to see is a peaceful coexistence where perhaps focal outbreaks may occur and the disease tends to become endemic per se. But when we say endemic, there are multiple issues that tend to come to one's own mind. When an epidemiologist thinks of an endemic, you talk of, he suddenly starts thinking that it is a constant presence of this particular virus. It is in equilibrium, and it is present in any geographic area that you tend to talk about. Now, if you look at the challenges that such a term like endemic can pose to you, is it easy to define diseases whether they have become endemic? No, you look at HIV. HIV, if you look at the incidence has gone down. But suddenly you find that there are certain subpopulations where the incidence continues to be high, whether they are sex workers, whether they are MSM, whatever injecting drug users, whatever we talk about. So essentially, it's very difficult to classify. Overall, it may sound as endemic, but there are certain pockets where it doesn't remain endemic per se. When it comes to malaria, in fact, we had the worst to accept that malaria was thought to be eliminated at one given point in time. It can come back. No, it came back. So essentially, anything that is endemic, it is a dynamic state. Endemic diseases can always come back again, is a thing which we must remember. Whether it is TB also has similar issues if you look at it from overall global perspective or a countrywide perspective also. How does one say that COVID has become endemic when the major challenges that you would have is the proportion of asymptomatic and symptomatic people? That tends to increase in viral evolution. So if they are asymptomatic, if they are subclinical, how do we say that the infection is endemic? Infection is occurring. Perhaps the severity of the disease is not as high as we had seen earlier. When it comes to testing, you suddenly have another challenge that tends to come. Testing has actually declined over a period of time that we have observed in the pandemic. If you actually look at infection and the detection, it tends to go down from 20 to 5 in Omicron because people were not coming forward to test. And what is also important is health-seeking behavior impacted the whole process in a strong way. To a policymaker, when you say it is endemic, they generally interpret it as not a major health problem, and that's also not a good issue because the focus perhaps tends to, in terms of interventions, tends to go down dramatically. To a clinician, endemic would mean something else. The number of patients with new infections are likely to be smaller, and the infection may become seasonal. Then perhaps they start thinking, yes, I am able to predict when it is likely to occur. The number of cases are going to be small enough. And what is also important for the clinician, that it may also connote to him that there are very few cases that would be hospitalized and most may recover. And that is what a clinician would think in terms of endemic diseases. When you think in terms of communication expert, when they talk in terms of pandemic becoming endemic, they would perhaps think that this means that you can perhaps change the risk communication related to acquisition and consequent severe outcomes for people to understand, for the awareness that you want to create about this disease. So endemic as a term is can be interpreted differently by different people, and the reason is very simple. If you actually look at factors that influence endemicity, there are factors which broadly fall under immunity, You might have immunity that may come from infection, and therefore proportion of people who may actually manifest with infection despite exposure will go down. The severity of infection may make it more undetectable. The waning of immunity also impacts endemicity. The immune escape as a phenomenon can impact the endemicity. There are different interventions, whether vaccine related or drug related or non-pharmacological interventions, and seasonality and interactions between different viruses can influence the endemicity per se. Do I need to worry as much? We need not worry until a new variant with higher virulence tends to develop in China. Looking at the current trend of evolution, one may reasonably be confident in believing that the world may be moving towards endemicity after this spike. If it goes down dramatically over next few months' time, you are perhaps moving closer towards endemicity, but still the infection is very much here. The outbreaks are occurring. Upsurge of infection is being seen in certain countries, and we cannot relax completely. Now, one of the good things, which to my mind, which is important to remember, when you have very high R0, it works against any organism. The reason is the duration of the surge. If the exposure is going to be respiratory exposure, and everybody is vulnerable, is likely to be exposed to it, then in those cases, the duration of surge is going to be smaller. If you recall, in Omicron, the wave lasted for a pretty short period of time compared to the other waves that we had seen earlier because it had a very high transmission efficiency. The shorter the duration of infection, no, you will find that there will be reduced likelihood of emergence. If you recall that even the incubation period is shorter for Omicron, the duration for which we tend to isolate a patient who had Omicron infection is also shorter. And therefore, if you look at these three factors, you will suddenly find emergence of newer variants with major mutations is unlikely to occur to my mind. One of the things that tends to come to one's own mind now that there is a confusion that you see among people who are taking boosters. If you compare this mRNA based data, what they did. Now we know that they have a bivalent vaccine where they are using variant from Omicron BA.5 and also Wuhan virus together to try and ensure that the protection levels tend to go up. If you look at one monovalent, which was Wuhan based, or two monovalent boosters, and look at the new FRNT response that you are actually seeing, and compare that with those who received bivalent booster, you suddenly find that even against those variants which are coming up, the response using bivalent booster tends to be little higher. Now, should we be then providing a bivalent vaccine in India? To my mind, as I say, this is one opinion where I cannot be very certain. But I would be the last person to say that bivalent vaccine should be provided in India. One of the things which we have to remember that we already had BA.5 infection in our own country, and I don't see any reason why bivalent mRNA vaccine should be given. And the reason I'll tell you why. If you look at the phylogenetic tree and look at all those variants which cause different waves, you will suddenly find not only from Wuhan virus, Omicron is far away. One of the ways in which I teach laypersons, I say these are real brothers. When it comes to alpha, gamma, delta, beta, to Wuhan virus. But when it comes to Omicron, it's like a cousin. And even in the Omicron virus, you find that the evolution is occurring at a rapid rate. And if you look at the branches that are being seen, you find XBB and BQ1. They are from different original lineage of BA.2 and BA.5, and they are far apart when it comes to phylogenetic tree, which means the entire evolution has gone rapidly in such a manner that there is every likelihood that a new kind of a virus which may emerge may not necessarily be closer to what we had seen in as Wuhan virus or SARS-CoV-2. Is that reflected very well in antigenic cartography? Even in antigenic cartography, you will find XBB and XBB1 and BQ 1.1 are located far away compared to rest of it, and therefore perhaps a new kind of a variant may come. Then in those cases, what should we be doing? No, we could perhaps use nasal vaccine that has been developed by Bharat Biotech. Now, this nasal vaccine is based on an adenovirus. No, this is a similar kind of adenovirus that we have seen used in Covishield. This is also from chimpanzee. However, this is adenovirus 36 instead of the other two, even the Russian Sputnik 1 that was also used earlier. But this is CAD 36, the adenovirus 36 per se. And what they have done is a spike protein which they have not used in the Covaxin. Covaxin was BBV 152, but BBV 154 spike protein has been inserted there. And therefore, you find that if you take two dosages, they think that it would really be useful in providing you mucosal immunity. And what would this mucosal immunity do? It will protect your airways, it will protect your nostrils. And if you are getting exposed to it, your mucosal immunity will fight and ensure that the new infection finds it difficult to actually enter inside the body. But there is a catch. No, they have been only able to provide immunogenicity data. Though they are conducting phase 3 trials, it is still incomplete. They have about 3,160 persons who are likely to be who are enrolled in this particular study. But they have done some interim analysis where they show that if you compare BBV 154, which is the nasal vaccine, and BBV 152, which is Covaxin, you find that the immunogenicity at day 42 is high enough. Now, why this becomes an issue? We don't have efficacy data, like we didn't have the efficacy data that was there for any of the vaccines that we have used. They were approved based on immunogenicity data. But there is another thing that we have to remember, that the responses tend to be good in BBV 154. Though they may not be very significantly different, they are significant, statistically different. We still have to wait for the numbers to increase, actually understand what might happen. What are the important issues that may come? No, it is also important that the way people will administer this vaccine nasally, which we have hardly ever done as often in public health programming, you will find that it will decide the take of the vaccine. If somebody has colds, would I administer the vaccine? Do I postpone? How much of it should be postponed? These are critical issues which we will perhaps understand over a period of time. But this is the first approved nasal vaccine globally, and we look forward to it more closely and try and understand what impact would it have. We need to adopt a better lifestyle with masks. Using a mask in community setting, if I am infected, the risk of transmission can be reduced by 19%. So can we not teach all the people who come to us that if you are sick, if you are having any respiratory ailment, why can't you use mask for some time? And the risk of acquisition is reduced by close to about 30%. In conclusion, there is a small risk that a new variant may develop and lead to resurgence of COVID-19, and which is being covered by being more vigilant and being better prepared as of now in India. Please remember, this is a small risk. It's a theoretical risk. So infections will continue to occur. They may not challenge healthcare infrastructure. If nasal vaccine proves efficacious, we may be able to protect ourselves better than most. We may need to adopt a lifestyle where we use masks in risky circumstances, and especially by those who are more vulnerable. Thank you. Hello.
Hello. I think all of us enjoyed the flashes of expertise of Dr. Raman's lecture. Dr. Raman, the question always keeps on hitting our mind